Thank you for joining our WebEx. Today we're going to be talking about the IV iron process and how to access outpatient IV iron. My name is Tom Stewart. I'm the Director for Ambulatory Care in the Regina area, and the infusion clinic was one of my areas of responsibility. I'm going to talk a little bit about how to access this clinic, and that will be followed by Dr. Ryan Lett, Anesthesiologist and Physician Lead for the Patient Blood Management Program, and he'll be talking about more of the clinical indications for IV iron and some of the options for ordering. Thank you for taking the time joining us today. The infusion clinic is an outpatient clinic located in the ambulatory care unit on the main floor of the Pasco Hospital. The clinic offers a range of services, including administration of blood and blood products, drug and electrolyte infusions, and therapeutic phlebotomy. The clinic sees on average 25 patients per day and is open weekdays from 7:30 to 4 p.m. Please note we're closed weekends and stat holidays. To access the clinic, simply send in a completed pre-printed order or any additional orders via fax. Our fax number is on the screen, 766-2881. Once these are reviewed or received, they'll be reviewed by a registered nurse who will then contact the patient to set up an appointment. Outpatient IV iron accounts for more than half of the patient visits in the infusion clinic. Last fiscal year, there were over 3,200 doses provided, which is an average of 13 clinic visits per day for IV iron. We have seen a significant increase in the last few fiscal years in the use of IV iron, which is illustrated in this graph. Due to the high number of referrals we receive in the clinic, we do have a wait for services. Currently, the average wait time for IV iron is approximately 4 weeks from the time the referral is received to the first appointment. Until recently, all patients requiring IV iron needed to come for a series of visits to the infusion clinic. For some patients, this meant up to 10 separate appointments. With the introduction of monopheric, patients will require either 1 or 2 doses. This will have a significant impact on wait times and will create additional capacity within the clinic to help keep up with demand. Please use PPO 673 for monopheric orders and fax in a completed PPO to the infusion clinic. PPOs can be accessed in 2 ways. One is via the RQHR intranet site on the PPO tab, and the other way is on a downloadable form from the saskblood.ca website. If you need any assistance accessing the PPOs from your office, please contact the infusion clinic and we can send you an instruction sheet on how to set this up. We look forward to being able to provide more timely access to IV iron for your patients.
Hi there, this is Ryan Lett. I'm an anesthesiologist who's been working in Regina for several years now. The last few years, I've also had the privilege of taking on being the physician lead for patient blood management in Regina. I want to talk today about just some practical things about iron administration. Tom covered our infusion clinic, and I've been talking about this for about 3 years now, and a lot of it comes from choosing wisely, is that we probably shouldn't be using blood transfusions as primary therapy, particularly if iron is available, because it may actually be a better long-term choice for patients, and certainly in the optimization realm of patients coming for surgery. Patients do better if they have their iron reserves replete and come in with a hemoglobin more than 130 grams per liter for their surgery. And we can do that without transfusion. The most common cause of anemia is, of course, iron deficiency. So this is how we probably should start thinking about patient blood management in a lot of ways. A lot of iron deficiency can be dealt with the diet. Now, I know milk companies have done a very good job of convincing you that you need to drink milk all day, every day. But if you look at the evidence on milk consumption, and the Harvard School of Public Health actually does a really good job on this, milk, and particularly the calcium intake, actually interferes with iron absorption. So if you're one of those people who drinks milk with every single meal, you might want to consider separating out milk from when you're consuming meat or other iron containing foods as a way of improving your iron absorption. The most iron dense foods that we see on the food lists out there are liver and oysters. So even introducing a small amount of these into your diet can make a rapid improvement in iron levels. The next step up on our pyramid is oral iron supplements. And supplements are a little bit of a gray box in the sense that the supplement industry isn't regulated. We'll talk a little bit more about iron supplements shortly. But you want to find an iron supplement that contains a reasonable amount of elemental iron. We've been recommending ferrous fumarate because it has one of the higher concentrations of elemental iron, and it seems to be relatively bioavailable with relatively few side effects. And we're going to talk a lot about intravenous iron next. Ideally, even on the pyramid, you shouldn't be getting to IV iron without trying both diet and oral iron first, unless you have a time window that that neither food nor oral iron will restore your iron stores in time, such as a surgical date coming up or an anticipated pregnancy date coming up. I'm not going to talk about erythropoietin, and I'm not going to talk about transfusion in this talk. However, transfusion should be reserved for patients who are unstable. So in an ideal world, we would actually be screening people. This slide says 4 to 5 weeks. In a perfect world, this would actually be 8 to 12 weeks before surgery, because that would allow us to actually try oral iron or food alterations to see if we can improve people's iron levels before they come for surgery. If we don't have that luxury, sort of the last window of opportunity is that 4 to 5 weeks before surgery. That would be the stage that if we can recognize and diagnose iron deficiency, if we get a patient in for an iron infusion relatively quickly, their hemoglobin levels will have a chance to rise over the next several weeks before surgery. One of the other take-homes is that while a lot of physicians are comfortable ordering ferritin, ferritin is only useful if it is low. If it is high, you can still have a patient who is functionally iron deficient. And in our testing algorithm, the percent saturation is a better marker of total body iron deficiency if the ferritin level is higher. There's been a few other algorithms that have come out. This is in the setting of heart failure. If a patient has a hemoglobin even at 150 grams per liter, it may be worthwhile to screen for underlying iron deficiency, as they may actually feel better or have improved muscular kinetics if they have their iron deficiency treated. You can see we're in the preoperative realm, we're targeting a change in hemoglobin is our goal, but in studies that have followed just iron levels, these are the cutoffs at the higher end of things that they're using. So if your ferritin exceeds 800 or your percent saturation exceeds 50%, then you need to stop iron therapy. There's different ways of calculating how much iron a person needs. This is the Ganzoni equation that is quite widely used. It does require doing a little bit of math. However, it is fairly widely available, and if you translate that into a patient weight with a varying level of hemoglobin, this is where they end up. And a lot of patients who are severely anemic will need between 1,500 and 2,000 milligrams of iron. As you can see, oral absorption takes quite a bit of time, and so if there's a deadline in place, sometimes they need to bypass the oral iron step to intravenous iron. However, if there is no deadline in place, then oral iron is certainly the safest and most cost-effective way of treating that anemia. How we've been recommending the oral iron is that patients try ferrous fumarate. 600 milligrams means 2 pills. You can start with 1 pill every other day and see how you tolerate it. And it should be taken on an empty stomach. Now, the best guidelines say take it in the morning before you eat anything. I know that's hard for some people who want to have their coffee or tea first thing in the morning. And if that's the case, because tea and coffee interfere with iron absorption, in those people it might be better to take it at bedtime on an empty stomach. It can be taken with a vitamin C containing supplement or juice. And ideally, we would be following up with everybody who has who starts an oral iron regime and see a hemoglobin rise of 20 grams per liter. There's one other way of ordering iron. Isomaltoside is unique in the sense that it allows for nearly total body dosing with doses of 20 milligrams per kilogram. So it allows you to give up to 1,500 milligrams in one dose. This is significantly higher than for iron sucrose. The order form for iron isomaltoside has this table or a similar table on it, and it will direct you sort of as to the best way to order that iron. Please just select one box on the order form, as some physicians have been checking off multiple places on the form, which leads to confusion at the infusion center. So the iron pharmacokinetics make a difference in what the side effects you'll see with the different types of iron. Both gluconate and sucrose are relatively short-acting irons in the sense that they dissociate from their carbohydrate molecule, and you get a relatively rapid rise in labile-free iron in the patient's bloodstream. This limits the dose that you can give at any one time. It also explains why you see some of these side effects if these infusions are run relatively quickly, particularly with higher dosing. Iron isomaltoside, on the other hand, is a very stable molecule. It has very low increases in labile-free iron, and so you don't tend to see as many rate-related infusion reactions. You can see the practical limitations of iron pharmacokinetics. Iron isomaltoside you can give up to actually 1,500 milligrams in 20 minutes according to the monograph. We're infusing it over an hour in the infusion center just to add a margin of safety, as some previous formulations of iron who claimed to have relatively rapid amounts turned out to not quite live up to their claims down the road. So far, isomaltoside has been very stable even at the 1 hour mark. Both iron gluconate and iron sucrose, you can see comparably, have significantly lower infusion amounts and significantly longer infusion times. There's been one trial comparing iron sucrose to iron isomaltoside. In the first 5 weeks, probably because of the increased dose given to the patients and because that iron stays in the circulation for quite some time, there's no sort of trough levels that occur with intermittent bolusing as with iron sucrose. You actually get a faster rise in hemoglobin for the first 5 weeks with iron isomaltoside compared to iron sucrose. By week 8, these differences are completely obscured, and so for our outpatient infusion center, we are currently recommending isomaltoside. You can also present this a different way in terms of what the acquisition cost per milligram per liter increase in hemoglobin is. There's been a number of studies that have looked at hemoglobin rise with different oral iron supplements or IV iron supplements, and ultimately what you're paying for is the rate of rise. Both ferrous sulfate and fumarate are effective. They both take about the same amount of time. Ferrous fumarate seems to have slightly fewer GI side effects, so that's the one we've been recommending. There's other oral iron supplements out there. One of the more common ones and heavily advertised is the oral iron IPC group. A lot of these claim to have safety, which I believe to be true, but when they can't find toxic doses, I suspect that there is a significant absorption issue. And when you look at studies in humans, it takes significantly longer, or you see a lower rate of rise in hemoglobin with these oral iron IPC groups. And if you plot that out on a linear graph as to how long it would actually take to arrive at a change in hemoglobin that is significant, it would take over a year using these IPC groups. And because the cost is higher, it actually works out better for the patient to probably just pay for intravenous iron. Both iron sucrose and iron isomaltoside are effective. Their cost to increase hemoglobin is comparable, even though the unit cost is a little bit cheaper for iron sucrose. And again, blood is reserved for those who are unable to make their own red blood cells or have an acute event that they need to get over. Comparing different types of iron, they've looked at the total number of visits. There's a significant cost savings in the visit amounts, simply because patients do not need to travel as much or as frequently or for as long of time if they receive a single or one or two doses of iron isomaltoside. So you can see that once visit costs are accommodated, this was a study out of the UK, that there was an 83% cost savings with the slightly more expensive iron isomaltoside. So as mentioned, the carbohydrate determines the side effects you see. So this is comparing iron isomaltoside and iron sucrose. Both are extremely safe. Both report probably less than 1 per 1 million for serious adverse events. However, when it comes to minor adverse events, there is a significantly increased number of patients in the iron sucrose group who experience hypotension. This is largely because of the rate of free iron increase that is seen with iron sucrose, and this is a rate-related event. So minor infusion reactions are still rare. They're less than 1%. However, if a patient is coming for multiple infusions over their lifetime, realistically it is only a matter of time until they experience some type of minor infusion reaction. The serious life-threatening adverse events are extremely rare. Infusion reactions are rate-dependent for sucrose, gluconate, and dextran. These are all self-limiting, meaning that if you stop the infusion and wait, they almost always improve on their own. They can usually be restarted with a lower or slower rate of infusion, and they rarely recur. In patients who have a history of multiple allergies, strong history of atopy or asthma, corticosteroids can be considered for pre-treatment or treatment of reactions should they occur. There is no role for the treatment of Benadryl in iron infusion reactions. Most centers that have reported them have more adverse events with the use of antihistamines than with just dealing with the iron infusion by itself. Other adverse events that patients should be aware of: about 10% of patients will experience some type of muscle or bone aches within the first 24 to 48 hours after infusion. There are no residual side effects, and NSAIDs provide relief. It's been described as having the worst full body workout ever, and it does get better. It is likely due to the rapid uptake of iron into muscle and bone. Some people who receive iron sucrose will pee a very dark colored urine. This is actually normal, as part of the iron sucrose complex is renally excreted, and patients should be reassured of the same. The other are common to both iron sucrose and iron isomaltoside, in that fatigue, nausea, vomiting, diarrhea, shivering, flushing, and headache are common symptoms, and these are generally self-limited and resolve on their own. Lastly, there is one reaction that is unique to iron dextran and isomaltoside. It has been described as the Fishbane reaction. And typically what happens is there is an acute onset of chest or back tightness without any other signs of anaphylaxis. It typically starts within seconds of starting the infusion. Once it is stopped, that sensation abates within several minutes, and it typically does not recur with rechallenge. One theory that has been suggested is that it is a complemented mediated response to microparticles in the solution. And it again abates within minutes without any sort of treatment. So you need to stop and monitor your patient and just make sure that they're doing okay. You would only treat them for anaphylaxis if they have other signs, including hypotension, tachycardia, tachypnea, bronchospasm, wheezing, stridor, or signs of edema. Thank you for tuning into this podcast. We want to point out that there are two different pre-printed order sets for physicians to use. PPO 290 is for iron sucrose, and we're promoting that one for inpatients where the nursing time is already available on the wards. We are using PPO 673 for iron isomaltoside for outpatients where having a throughput of patients to accommodate the growing demand for outpatient iron is extremely important. Thanks for tuning in.